Assalamu alaikum wa rahmatullahi wa barakatuh. The article for this week titled as Endodontic Microsurgery Outcomes Over 10 Years and Associated Prognostic Factors, a retrospective cohort study. This study was done by a group from Korea, led by Yu et al. In 2024 and published in the Journal of Endodontics. Endodontic surgery aims to eliminate persistent periradicular inflammation in teeth in which non-surgical endodontic retreatments have failed or retreatments are restricted by anatomical complexities. With advances such as surgical microscope, ultrasonic root end preparation, and biocompatible calcium silicate materials, endodontic microsurgery has demonstrated improved outcomes compared with traditional apical surgery. However, most available evidence focuses on short or mid-term outcomes, while long-term data remain limited. So the rationale from this study: the previous long-term studies on endodontic microsurgery show inconsistent results due to variations in surgical techniques, operators, materials, and follow-up duration. Additionally, healing outcomes might decline over time, making long-term essential. Therefore, this study was designed to provide long-term data using a standardized protocol and single operator. So, the aim of this study was twofold. First, to evaluate the long-term success and survival of teeth treated with endodontic microsurgery over a period of 10 to 17 years. And second, to identify prognostic factors associated with reduced or improved the outcomes. Let's move to the materials and methods used in this study. This was a retrospective cohort study conducted at Seoul University Dental Hospital. All included cases underwent endodontic microsurgery between 2006 and 2013, with a minimum follow-up period of 10 years, extending up to 17 years. For the inclusion and exclusion criteria, they included adult patients who provide informed consent, had complete clinical and radiographic records, persistent preapical lesions after endodontic treatment or retreatment, adequate coronal restoration, and at least 10 years of post-operative follow-up data. For the exclusion criteria, patients were excluded if they lacked adequate records, had uncontrolled systemic disease, were pregnant, under 18 years of age, teeth with severe periodontal disease, root fractures, perforations, cracks, or advanced preapical lesions. So, out of 721 initially treated teeth, 309 teeth meet all inclusion criteria and were available for long-term evaluation. The mean follow-up period was 152 months. All surgical procedures were performed by single endodontist using a standardized microsurgical protocol. This included surgical microscope magnification, ultrasonic root end preparation to the depth of 3 mm, and retrograde filling with ProRoot MTA. Clinical and radiographic outcome were assessed by using Reed and Molfen criteria. Teeth were classified as successful if they showed complete or incomplete healing without clinical symptoms, and as a failure if uncertain or unsatisfactory healing or extraction occurred. For the results, the study reported a 10-year survival rate of 80% and overall success rate of 63%, and several factors were significantly associated with reduced success and survival. These included posterior teeth, presence of tooth mobility, unfavorable crown to root ratio, poor canal obturation density, absence of full coverage crown restorations, and large preoperative preapical lesions more than 5 mm. The most common reason for failure was root fracture, accounting for 42% of all extractions. This was followed by periodontal disease, which contributed to about 22% of failures. Failure to heal after microsurgery represented 12%, while crown fracture due to caries accounted for 11%. Persistent post-operative pain was responsible for around 9%. So, in conclusion, the preoperative status and condition of the tooth, including presence of tooth mobility, unfavorable crown to root ratio, poor canal obturation density, absence of full coverage crown restorations, and larger preoperative preapical lesion, might be relevant prognostic determinants of success and survival after endodontic microsurgery over the time. So, for the limitation of this study, several limitations should be acknowledged. First, this was a retrospective study, which is inherently a risk of selection bias. Second, the recall rate was low, with only about 43% of the original cohort available for long-term follow-up. Another limitation is that periapical healing was assessed using 2D imaging, which might underestimate healing compared with the CBC imaging. And thank you.